Good evening, everyone. Thank you for those present here in the audience as well as those online. I'm Bradley Hardy, Dr. Hardy, Medical Director for Warren Clinic, and here with us today are Dr. Nina Williams and Dr. Sarah Shaw, two cardiologists with the Warren Clinic Cardiology Group here talking about women's heart health. So I want to thank you all for coming and being here with us, and we're going to go ahead and get started. So with that, I'd ask Dr. Williams to go ahead and maybe tell a little bit about herself and what brought her into medicine, as well as specifically cardiology.
Hi there, I'm Nina Williams with Cardiology of Tulsa here at St. Francis. I grew up partially here in Tulsa. I was middle school and high school here, went to Holland Hall, and then did all my training out in the East Coast. Did cardiology fellowship at University of Louisville in Louisville, Kentucky, and then came back in 2020 and started practice here. What brought me into medicine and cardiology was actually just a family member, my grandmother, who had heart failure when I was 16, and I helped take care of her. And of course, at the time, I didn't really have a good grasp as to what it meant, what it entailed, and her mortality and so forth. But it was that experience of taking care of her that kind of shuffled me into medicine. Plus, my parents are from Ghana in West Africa, and all African parents want their child to be a doctor, so that helped. So here I am enjoying Tulsa. I have a lovely growing family, 2 little girls and a husband, and I've been loving the patient population here in Tulsa.
Thank you very much for that, Dr. Williams. Dr. Shaw, similar question, upbringing and kind of what drew you to cardiology.
So I'm Dr. Sarah Shaw. I'm not from Tulsa. I'm actually from Metro Detroit. I ended up here because my husband that I met in residency is born and raised in Tulsa and wanted to move back. I like Tulsa. It's been a wonderful place to live, but we've kind of lived all over the country. I got into cardiology and medicine in general. My mom was a type 1 diabetic and had her first heart attack when I was a freshman in high school. And I helped kind of, that obviously piqued my interest. I didn't, again, understand the severity of it at the time, but truly kind of a scary situation. And I kind of helped manage her care throughout the rest of her life.
It sounds like you guys both have very close ties to cardiology and very early experiences, whether it be heart failure with your grandmother or having a mother who had a heart attack early in life. Those are 2 specific examples, but on a broader perspective, can you guys kind of talk about traditional risk factors for the development of coronary artery disease specific to a female patient?
Sure. So I'll start. So the typical risk factors include high blood pressure, high cholesterol, diabetes, smoking, a family history of heart disease, and obesity. And of course, any of those things can be in a man or a woman. And 5 out of those 6 things can actually be addressed and optimized as a patient or any individual. And then in women, there are additional risk factors that kind of go alongside that, one being menopause. When women reach menopausal age, we have increased weight gain, central obesity begins. There can be changes in your cholesterol panel and your lipids. We start to see more elevated blood pressures. Secondly, a diagnosis of polycystic ovarian syndrome, or PCOS. Women who carry that diagnosis also tend to have more central obesity, a propensity for diabetes, and so forth, hormonal disturbances that can contribute to those risks, the 5 risk factors that I mentioned earlier. Breast cancer is one that sometimes I don't think is at the forefront of people's minds. Men and women can both get breast cancer, but of course it's more prevalent in women. And with breast cancer, the chemo, the radiation, there then can be the sequelae of heart failure from those therapies, and also coronary artery disease. And autoimmune disease is another feature that tends to be more prominent in women than men, and having underlying autoimmune disease can also lead to cardiovascular disease in the future. So those are some things that are more specific. Oh, and then pregnancy. Women in pregnancy, if you have the child is born early, greater than 37 weeks, increases your risk for cardiovascular events in the future, having gestational diabetes, having high blood pressure during your pregnancy, having preeclampsia. So these are all women that we need to be capturing and screening in the pregnancy ages and then also in the menopausal ages, so all women.
Thank you for that, Dr. Williams. I know as a primary care physician or in the general community, people always talk about chest pain or acute coronary syndrome, having a heart attack as, crushing substernal chest pain with radiation to your left arm and jaw. How that we associate it more with a male patient. Can you kind of explain some of the differences, Dr. Shaw, between a male and female potential MI patient?
So women tend to have more atypical symptoms rather than that crushing, elephant sitting on your chest pain. One of the most important factors to take into consideration is diabetics. So my mother was a type 1 diabetic and never had any chest pain ever. She had 4 heart attacks and she never once had chest pain. I remember when I was a freshman in high school, we were on a vacation in Seattle and we were walking, hiking, and she was profoundly short of breath. To the point where she had to stop on multiple occasions. She was told that she was having panic attacks and she was overweight and, was blown off on multiple occasions till she actually had a heart attack and her primary ended up sending her to the hospital, and she got 2 stents. So a lot of times I've seen women more with like nausea, vomiting symptoms. Sometimes it's jaw pain or pain that radiates down your left arm. Sometimes flu-like symptoms, specifically like nausea, vomiting. Shortness of breath is a big one. So if you are noticing that you are getting more short of breath doing stuff that you're not normally, normally you could do the activities and now you're having a hard time, that's definitely an indication that you should make an appointment with your doctor. I always tell people, I don't expect you to run a marathon, but if you're getting short of breath walking up a flight of stairs where a year ago you weren't, if you're getting short of breath doing housework, those are all signs or symptoms that there may be a problem. It's not just crushing chest pain. Sometimes the chest pain that women have is also more sharp, not quite as like a heaviness or pressure. Obviously, chest pain is a concerning sign or symptom, and that's an indication to get evaluated immediately, but also, watch out for the jaw pain, toothaches, pain that radiates up into your neck and your jaw with exertion, pain that radiates down your left arm, any change in activity tolerance, all good, especially if you're diabetic, are good reasons to get evaluated.
You specifically talked about, shortness of breath going upstairs or exertional or chest pain brought on with exertion. How do you feel, or what do you think is the most important thing to educate patients about atypical symptoms? Like what can they do to be proactive and not discount what they're experiencing?
So usually, I always tell people it's always better to be safe than sorry to get checked out. There's no dumb reason to come into our office. If you're having any concerning symptoms, we're always here and happy to evaluate you. Specifically with my mom, I watched her go to a cardiologist who told her that she's having panic attacks and didn't order any testing on her. And she was only 30 or 40, I think she was 41 years old. She's young. So, I really try in my practice not, to work up everybody, take into the risks. I think the most important thing is to know yourself, and if you're having new symptoms, there's 2 different ways that you have a heart attack. So one is progressive atherosclerosis, where the artery kind of narrows down, and that's what we usually look for exertional symptoms. So usually, as if you have a plaque that's around 50% or less, it's not going to cause any symptoms. As that plaque progresses and it starts to get significant stenosis, around 75 to 80%, you start to notice symptoms. That's when you're going to get, exertional component. But a lot of people, when they have chest pain, as a plaque rupture, and that's can happen in any size plaque. And so usually whenever you come into my office, I try to educate people on like signs or symptoms. You may not have that progressive exertionals if you're not having progressive plaque buildup, if you have a plaque rupture. So if you have acute symptoms that are really new for you, it's never a bad idea to get evaluated. You can always go into your primary care office, urgent care, things like that. My personal opinion is always best to be evaluated and not wait. Because time is muscle, so the sooner you get evaluated for heart symptoms, the better off you can be in terms of recovery.
An important point to focus on is that time is muscle, and the heart can be damaged just like any other part of the body, such as, stenosis or blockage leading to somebody having a stroke. You can think about it as the same principle. That being said, you talked about 50% or less than 50% stenosis being asymptomatic. Do you guys want to comment about potential screenings or testing that patients can undergo to look for early disease in the absence of symptoms?
So it starts with optimization and identification of the risk factors. So the things that I mentioned, seeing your primary care yearly to have your blood work checked. So number one, they screen you with a blood pressure check as soon as you walk in, and then they'll get a full set of labs looking at your fasting cholesterol, checking an A1C to see if you have diabetes. So trying to identify those risk factors that would increase your overall risk of development of coronary artery disease. And then if those risk factors are present plus symptoms, like Dr. Shaw mentioned, not necessarily the classic symptoms, but noting a change in your activity level over time, new shortness of breath, chest pain, jaw pain, so forth, we take the combination of both those two things and say, what is the best diagnostic test to diagnose if you have a problem, and then how can we treat said problem if we find it. So some of that testing includes stress test, either giving you a chemical to stress your heart and taking pictures of the heart before and after stress of the heart, or a stress test on a treadmill. And I think oftentimes patients hear stress test and they think, I have to get on a treadmill. Not necessarily. We can give you a medication to somewhat mimic the same sort of physiology or function of stressing the heart. Additionally, we can do CT scans of the coronary arteries to show us if there's any soft plaque or any calcified plaque in the vessels of the heart. And depending on what we see there, plus your symptoms, then kind of leads the way to further investigation if necessary. An echocardiogram, which is an ultrasound of the heart, same sort of thing they do for pregnant women, but it's actually looking at the heart to look the squeeze, the function, look at all the valves, make sure everything's moving and functioning as it should. And then the routine EKG, I made a joke the other day that it's a cardiologist's handshake, but we get a lot of good information just from a routine EKG that primary care physicians are doing at yearly visits, and they are noting something might be a little abnormal here. I can't tell you the number of patients we've both seen that have come in because their primary care doctor did an EKG, it was a bit abnormal, they came to see us, and we found significant things. So those are some of the testing modalities and so forth to work patients up. But it really boils down to seeing your primary care doctor and establishing that relationship so that somebody's kind of always watching, and they can help triage you to come and see us as well.
Thank you for that plug for primary care. As a
welcome.
family practice physician, I think that's incredibly invaluable. I make a point to try to see every patient every year, and I don't just keep refilling medications out of habit, but I want them to come into the office to be seen, to get that basic blood work, looking at cholesterol values, looking at blood pressure. Talking about blood pressure, I know there have been some changes in the past couple of years that some people might not be aware of in regards to goals. If Dr. Shaw wants to take this one or kind of opine as far as tailored goal-directed therapies or not goal-directed therapies, but just basic American Heart Association guidelines for blood pressure control, both in people over 65 or the younger population.
Yeah, so blood pressure, again, it depends on risk factors. So, the more risk factors you have, diabetes so we're going to talk a lot about diabetes up here. Diabetes is something called a coronary artery disease equivalent, meaning that it puts you at such a high risk for developing heart disease that we treat you like you have it when you walk in the door and get diagnosed with it. So a lot of times your cholesterol goals are much tighter, your blood pressure goals are much tighter. Usually in my office, blood pressure, obviously we don't want blood pressure to be too low. So we kind of work in the range of the 120s to 130s systolic, that's the top number, then 70s to 80s diastolic, that's the bottom number. That's really the goal for blood pressure. Usually if you're younger or you have a lot of symptoms, we can kind of tailor your program to you individually. I don't have a one size fits all with everything. It totally depends on your risk factor symptoms. If you have any kind of aneurysms or dilation of arteries, obviously we want much tighter blood pressure goals with the top number under 120. A lot of times though with blood pressure, it depends on how you feel. So some people, I can walk around with a blood pressure of 95, which I normally do, and you may feel terrible with that blood pressure. So it's a lot of times it's a very tailored, we kind of go by how you're feeling and your symptoms.
I think that's important to focus on as far as the individualized approach and what their risk factors are. Talking about blood pressures, how do you all feel about home blood pressure checks for patients on hypertensive medications? And if you think that's a good thing, and if so, how often? And maybe give some insight as far as what kind of cuffs you think might be a good option for people, not specifically brands, but just, wrist versus upper extremity on the humerus, et cetera.
Sure. So with home blood pressure monitoring, if you have risk factors or you are on blood pressure medication, you should be checking your blood pressure at home. I have patients that come in and say, my blood pressure was fine, and now it's elevated at 180 over 90. And I ask, well, have you been checking your blood pressure at home? Yes, the last 3 days, and it's been high. How about last month? No, I just started 3 days ago. So then how do we know that blood pressure hasn't been high unless it's being checked? And so I recommend a blood pressure cuff that goes over the upper extremity. It's better than the wrist. There are some patients that can't use their upper extremity for one reason or another, so then the wrist is better than nothing, is what I've said. And if you're being evaluated for a new elevated blood pressure, a new diagnosis of hypertension, we tweak your medications closely, and I have those patients check their blood pressure twice a day. The first blood pressure should be taken 30 minutes to 1 hour after you've taken your medication. Everybody's blood pressure is elevated first thing in the morning. You get out of bed, you have this adrenaline dump, we get up and moving, going, and your blood pressure is high. Then it should slowly start to settle. And in those who are hypertensive, it never really settles. It just kind of, it settles at a higher level. And then when you get excited, it goes even higher than that. When you're relaxed, it stays at the high level, and so forth. So when we're tweaking blood pressure medications, that's my recommendation, 30 minutes to 1 hour after you take your blood pressure, and then a second time in the evening. And then bringing that into your cardiologist or to your primary care physician so they can see what your true blood pressure is. Many times when you come to your physician's office, your blood pressure is high, and it's like, it's never high at home. Well, the factors that contribute to that, the parking, and then somebody was rude to you in the hallway, and then the check-in lady asked to see your ID card again, and then we check your blood pressure while we're talking to you, and then it's high. So we do not base our blood pressure medication recommendations off of office visit blood pressure readings. It's the home ambulatory readings that carry most weight, and that's where these blood pressure logs come into play. Now, let's say you've been on blood pressure medication for a while and your blood pressure is well controlled. Do I really need to take it? Those patients that we found a sweet spot, they're great with their diet, things aren't really dynamic, I say once or twice a week. So then that way, if you see an elevated reading, you can then start taking it daily to see if things are changing, because the body's dynamic and not a perfect machine. And as we start to hit certain ages and so forth, the body chemistry changes, the arteries get a little bit harder, and so those are my general recommendations.
I'll caveat that with when you do check your blood pressure at home, you want to be sitting down for about 15-20 minutes. It's normal for your blood pressure to go up when you walk around, walk up a flight of stairs, carry heavy things. So don't check it right after you have just done one of those activities. And then the other thing is diet also will play a part in that. So if you're going to go have a Big Mac and fries, probably not the best time to check it after that.
In my practice, I've encouraged patients periodically to bring in their home blood pressure cuff as well as machine. Do you all think that that's a good idea when we're seeing that large variation in between home and in-office readings?
Yes.
Great idea.
Yeah, we correlate blood pressure cuffs all the time. And usually the home ones are pretty accurate.
Talking about accuracy, kind of changing gears, and not specific to blood pressures, can you all, a lot of patients nowadays are wearing or are utilizing wearable devices such as Apple Watch. They recently came out with their Generation 3 and higher offers an EKG tracing where it will fire if you go into an abnormal rhythm. What is the accuracy of this, and is it something to be worried about?
I personally think the accuracy of the Apple Watch is fantastic. I think that it is on par with our monitoring systems that we have in the hospital. It's usually, I personally think the 4th generation or higher is better. But in terms of SVT monitoring, AFib alerts, I've had numerous patients catch AFib with monitoring with Apple Watches. I think it's fantastic technology. If you're comfortable using the Apple Watch, you can set up heart rate alerts, and then you can set up AFib alerts, and the more you wear it, the more helpful it is. But I have people monitoring their heart rates, like that'll give you an average heart rate, and people that have chronic AFib with just an Apple Watch, and we don't even go to our own monitoring systems.
Yeah, and just to kind of echo what she's saying, with those people that are newly diagnosed with an abnormal heart rhythm, particularly if it's AFib, then they come in to see us, and we're able to start them on the appropriate therapies to decrease their risk of stroke big time. So it's great technology, and I also support its use.
Atrial fibrillation. Some people in the room might not know what it is. Others may. It's definitely, I don't know if I could say this with certainty, but I feel like it's the most common arrhythmia, at least that I see. Could you all describe what that is and what a patient might be experiencing if they encounter that?
Sure. So atrial fibrillation is an irregular heart rhythm where the heart's not beating nice and steady. So normally the natural pacemaker of the heart kind of beats nice and steady if you're sitting and listening to us. If you're running up a flight of stairs, it's going very, very fast. And in AFib, it's just bouncing all over the place. And when the heart is not beating nice and normal, the blood starts to pool. And when blood pools, it clots. And then when clots form, they can shoot into the brain and cause a stroke or get stuck elsewhere and cause problems downstream. And so that's why we all get so worked up about AFib, because it can cause a stroke. Unfortunately, we see a lot of patients in the office after they've had their stroke, and that's how they were diagnosed with atrial fibrillation. So early detection is of the utmost importance if you're able to catch it. Risk factors that contribute to the development of atrial fibrillation. So pulmonary disease is a big one. Anywhere on the spectrum of reactive airway disease, asthma, COPD, sleep apnea is huge. Thyroid disturbance. So if you have hyperthyroidism that's very out of control, can tip a patient into atrial fibrillation if they have that substrate of their heart just has a propensity for it to actually happen. Being critically ill in the hospital can tip patients into atrial fibrillation. After having heart surgery, you can have AFib. We also oftentimes see patients that come in as like, oh, I was going from a cataract surgery, and they said I was in AFib. And I said, well, this is good that we found out now. Otherwise, it could have been bad news down the road. So, and symptom-wise, some patients don't feel a thing. And then other patients might feel as their heart is racing or skipping beats, or they feel that they need to sometimes take a deep breath to try and catch their breath, and then it passes. Those are some of the symptoms that are experienced.
You talked about airway disease being a risk factor. Specifically, or this is more of an educational point, they're talking specifically about, things like COPD or emphysema, things associated with a smoking history. If you have a smoking history, that's putting you at increased risk. Okay, so moving on, you guys touched on this earlier, but what kind of a role does menopause play in the development of coronary artery disease?
So if you look at the data, like the Framingham, that's like the biggest heart trial where they studied these people for like 20, 30 years. Women that are premenopausal have a lower risk of cardiovascular events. So natural estrogen is protective. So when you're premenopausal or still menstruating on a regular basis, compared to your male cohorts, your risk is actually lower. Once most women hit menopause, the risk equilibrates. So now you go from your male cohorts here, all of a sudden you're up here, and they've done a lot of studies with exogenous estrogen replacement, and that does not help. It actually increases your risk of cardiovascular events. So we do not recommend estrogen replacement therapy as a cardiovascular risk. It actually is not recommended at all. But that's basically what happens is once you go through menopause, your risk of cardiovascular disease as a woman does increase.
Thank you for that. I know we talked about this a little bit earlier as well, but Is there a easy way, or nothing's easy in medicine, let me backtrack that. Um, is there a way to distinguish cardiac chest pain in women's in comparison to other factors such as, potentially having reflux at night or heartburn?
So we see a lot of, as you can imagine, a lot of patients with chest pain. And it's important to try and tease out some of these other things that cause chest pain. And I tell patients all the time, yes, your heart is, in my opinion, the most important thing in your chest. But there are other things there too, like the esophagus, the lungs. And so if you're having chest pain that's related to esophageal disease or problems such as acid reflux, it's all in the history. So we ask about, well, does your chest pain come on after you have a meal? Yes, as a matter of fact, I go and lay down 20 minutes after I eat and it's just burning and it feels terrible. That's probably more so acid reflux. Esophageal spasms can feel like a true heart attack. Some patients have those. If you have pleuritic chest pain, which is chest pain of the lungs or with breathing, that can feel like you might think that that's heart pain when it actually isn't. If patients have, this is a little not as common, but if they have clots in the lungs, blood clots in the lungs, that can feel like a heart attack chest pain. And then you also have the aorta in your chest wall, and if there's a dissection or a tear there, that can feel like crushing chest pain. So those are some of the more dramatic things that we see in the hospital, that there are thoughts that maybe it's my heart when it truly isn't. And so how do you tease those things out from actually it is my heart? It's the story that you have to tell plus your risk factors. So a 21-year-old who comes to see me and tells me that she has a lot of life stressors and is having these chest pain symptoms, but she is a healthy weight, she doesn't smoke, she does not have high blood pressure, she has no family history of heart disease, the likelihood of the chest pain she's describing being cardiac is lower. So it's the combination of the two things that kind of help us tease things out.
Hopefully this means that we got the audio working online for those in attendance virtually, because we were running in the dark here for a while for those here in the studio audience. But we had a question come in. Do you feel there are any additional labs that need to be added to the gold standard that we discussed earlier, such as thyroid function, lipid panel, something that the patient should bring up to their primary care physician before seeing you?
So family history is a very significant risk factor for coronary artery disease. So a lot of times, we can modify a lot of things, but we cannot modify your genetics. So if heart disease runs in your family, aunt, grandma, great-grandma, multiple cousins have all had heart attacks, or male side too, below the age of 65, that puts you at a risk for premature coronary artery disease with significant family history. Also, a lot of times that runs hand in hand with a familial hyperlipidemia, meaning that usually you have a genetic component that your cholesterol is high. There's 5 types of familial hyperlipidemia. Some increase your risk more of having heart attacks and some don't. But usually there's the family history plays a huge part in it. So if you have a premature family history, a lot of times there is a blood test called a high sensitivity CRP or cardiac CRP that we do check, that checks for inflammation in your arteries. Sometimes that's helpful if your cholesterol is kind of borderline, or if people are kind of hesitant to get on medical therapy. That's kind of a good motivator to initiate therapy. I will check that. Sometimes if you have a significant family history, getting a calcium score or some other type of screening for premature coronary artery disease is very helpful. I think the most important thing though is, I always live in the I'd rather be safe than sorry. Get evaluated. So if you have concerning symptoms, just get evaluated. We're happy to evaluate, like Dr. Williams said, we ask a whole lot of questions. So when you come in and see us, we ask a huge panel of questions. We ask a lot of, when does your chest pain come on, or your shortness of breath, or it's a detailed exam, and that tries to help us figure out what the issue is. If we don't know, or if your primary care doctor doesn't know that you're having these symptoms, we can't help you.
You kind of hit on cholesterol management and medications and looking at laboratory to help guide that. For those patients who are reluctant to want to go on to cholesterol, a statin or a beta blocker, can you talk about some dietary changes or lifestyle modifications that might benefit these individuals to kind of give them the college try, so to speak, as maybe three months off or 6 months before we really have a serious conversation about needing to go on medications?
Yeah, so if a patient's cholesterol needs to be optimized and they don't want to take medications, I say, okay, well, prove to me that you can bring down your cholesterol. And what that entails is following a heart-healthy diet and engaging in routine structured exercise. So about 40 minutes a day, 4 times a week, it counts as routine, and your heart is beating, pumping, you cannot carry on a conversation, you're exercising. And so that should be, that should be the goal when it comes to exercising. But as a caveat to that, any movement is better than no movement. So if you can't run or jog, you don't have access to a gym, everyone has access to outside. So getting outside and walking is better than no exercise whatsoever. Secondly, with the diet, across the board, regardless of one's diagnosis, if they have cancer, if they have liver disease, kidney disease, heart disease, a plant-based diet or a plant-forward diet has shown to be of most benefit. Helps decrease inflammation, decreases your cholesterol overall that's depositing in the coronary arteries, as Dr. Shaw said, that then leads to stenosis or atherosclerosis. A plant-based diet is ideal. Decreasing fried foods, trying to stay away from the sugary foods, processed foods, having more fruits and vegetables. That's the basis of the diet that should be followed, but more so of a lifestyle choice. I hate to use the word diet, but it's more so of a lifestyle change. And not everyone has access to shop at Whole Foods, which is extremely expensive. But a whole paycheck. But using the resources and things that you have around you, and also portion control is another thing I tell patients. That if your plate is this big and it's always full, how about cutting it in half and having half of that for lunch and the other half for dinner? Those sorts of small changes go a long way.
I think it's important what you talked about in regards to not viewing it as a diet, but more so a lifestyle change, because diets aren't sustainable, but lifestyle changes are. And I can echo what you talked about in regards to more of a plant-based diet. I office out at St. Francis South, and 2 of the cardiologists who work out there, they're vegetarians. So the other plug that I'd say is my wife and I really enjoy the cookbook, How to Not Die. It kind of is a provocative title, but it's written by a physician, and there's an accompanying novel that was a New York Times bestseller. So just Google How Not to Die cookbook, and you'll find a good resource for more of a plant-based diet. We had a question come in over the internet, asking if you all would mind addressing PVCs, what they are, how they're managed, what the presentations are.
Sure. So we're going to switch gears. So I always tell people to think of your heart like a house, okay? You got a plumbing system and an electrical system. So plumbing problems is heart attacks, that's blocked up pipes. Electrical issues, what they're talking about, like with AFib or abnormal heart rhythms, that's an electrical problem. Sometimes they're related, but a lot of times they're separate. So we already touched on AFib, that's an electrical problem. PVCs are an electrical issue. They're extra heartbeats from the bottom chamber of the house, so bottom chamber of the heart. So again, we're going to go back to the house, upstairs, downstairs. So the atrium or the upstairs of the heart, there you can have something called premature atrial contraction. So along with the cells, the muscle cells that help the heart contract, there's electrical pathways, and a lot of the cells are able to auto-generate heartbeats. That's a backup system in case your internal pacemaker goes out, your heart can still generate heartbeats and you don't die. But sometimes those can become irritable, and you can auto-generate heartbeats from places that it shouldn't be happening. So upstairs, there's something called the SA node, and that's the internal pacemaker that sets your heart rhythm. It travels through the upstairs, down to the downstairs, and then it contracts and it pumps the blood out. So PVCs are extra beats from the downstairs, the bottom chamber of the heart. Depending on where they can be located in multiple areas. Some people just have more electrically active heart cells, so PVCs are not abnormal, meaning a lot of people have them. Some people feel them and other people don't. So the things that we get concerned about with PVCs are the different morphologies. Are you having them from one spot? Or are they coming from multiple places? How many you're having in a 24-hour period. So usually the workup for PVCs or palpitations or extra heartbeats, or as we check to make sure your heart is structurally normal, we usually check some kind of monitor to see how many PVCs you're having in a 24-hour period. PVCs are usually able to suppress with exercise and sometimes medication. If you don't have a huge PVC burden, it doesn't necessarily have to be treated. If you're having a lot of symptoms with it, we can address that there. But mostly they're just abnormal heartbeats from somewhere in the bottom chambers of the heart.
Thank you for that. When people, with that answer, you kind of talked about what to expect and, ways to kind of monitor or look for these things. Would you guys kind of mind explaining exactly what a lot of people I'm sure have heard this expression but might not know exactly what it is, but a Holter monitor versus a 30-day event monitor versus an implantable device, and kind of where those fall into the spectrum of practice?
Sure. So the Holter monitors can be ordered for 24 hours, for a week, for 14 days. And the 30-day event monitors are 30 days. Those are more live streaming, if you will, to some extent. And really what dictates what sort of monitor we order is the frequency of one's symptoms. If you tell me that, I feel these palpitations or fluttering every day, I have them all the time, it's happening right now, that person doesn't need to wear a 30-day event monitor. She can wear a 24 or 48-hour heart monitor. If you say it happens once or twice a week, or maybe, once or twice a week, that patient I might put on a 30-day event monitor. If somebody is saying that I am passing out, and I also have palpitations, I'm passing out, that patient I might put on a 30-day event monitor because we don't know when you might potentially pass out. If your symptoms are severe to the point, but very infrequent, maybe once every 3 months, that's the person that will try with a short-term monitor to see if we capture anything in a 30-day period. And if unsuccessful and still having issues, for instance, I do have some patients that have had passing out episodes and associated palpitations or fluttering, then we talk about putting in what we call a loop recorder, which goes right underneath the skin. It is not a pacemaker or a defibrillator. It does not control the heart or pace the heart. It just watches. And it can sit underneath the skin for up to 2 years, is what I quote, 5. Yeah. So it stays in even longer than I thought. But I tell patients it stays in for 2 years, and it just watches and watches and watches. And if there happens to be that rare event, we can then go and look at the data and say, hey, this is what your heart was doing when you had whatever event, and see if there's any correlation, and then address it at that time. But I do want to assure you that your cardiologist will order the appropriate monitor for you.
I have no doubt that you would order the appropriate monitor for anyone in this room or on the call. So we know we talked about presentation of a heart attack. If that happens, or if patients are experiencing those symptoms and they end up going to the emergency department and they're actively having what's called a STEMI, or an ST elevation myocardial infarction, can you kind of walk us through this, what would transpire on the patient's behalf and ending at the point of potentially going to cardiac rehab?
Sure. So if you come into the ER and you're having a heart attack, things move very, very quickly. So usually what will happen when you come into the ER with chest pain is they try to get an EKG as soon as you get here within a reasonable amount of time. And that's kind of the goalpost of what's going on. So an ST elevation MI is a very specific thing telling us that you're having an acute heart attack. If that happens, you'll get taken back to a room. You're going to get hooked up to IVs. They're going to give you a bunch of medication, usually and a little drink that you drink, and you're going to go right up to the cath lab. So a heart catheterization or an angiogram is something that we do to assess for blockages in the heart arteries. And it's kind of like the plumbing analogy. We basically squirt IV contrast dye underneath an x-ray machine, and it literally shows us where the blocked up artery is. So you'll go from the ER, usually, hopefully within 90 minutes, up into our cath lab. They usually get access either the artery, the wrist, or the artery in the leg, the femoral artery. And we go up with it's literally a catheter, and we squirt contrast dye in your heart arteries and check for blockages. I think Dr. Harrison and Dr. Joseph are going to touch on this next week, by the way. But, so stay tuned. They will have a lot more information about that. They're both interventional cardiologists. But usually we find the blockage and we place a stent. So a stent is, so we're going to go back to the plumbing analogy. We find a blocked pipe. So, you got to roto-rooter it out. So what we do is we cross it with a wire. We put a stent, which is over a balloon. So basically we cross the lesion with the wire, put the stent on, we expand the balloon, and then you kind of open up the blood flow so the plaque gets kind of smushed up against the arteries. Sometimes they'll try to suck out the clot, depending on how big it is, with a little suction device, and then you restore the blood flow to the heart. And right after that, you're taken to our cardiac floor. Usually you're obviously monitored for up to 72. Usually we keep you here for 72 hours to monitor you for abnormal heart rhythms. The first 48 hours are the highest for something called reperfusion arrhythmias, where we see abnormal heart rhythms post-MI. Depending on how your heart function is and how your symptoms are, depends on how long you stay here with us. Usually we'll put you on a bunch of medications, adjust those medications depending on what you need. I think most people, if everything goes very smoothly, are out of here within around 72 hours. If you have some issues, you may be here longer. We do arrange follow-up in our office, and then what Dr. Hardy talked about is cardiac rehab. So cardiac rehab is very near and dear to my heart. I think it's very important. So cardiac rehab is a supervised exercise program for heart patients, actually for anybody that wants to participate if you're willing to pay $99. But basically what it is for people that have had a heart attack or stents or heart failure, it is a supervised exercise program in our hospital down on below the parking garage, and they basically there's 4 different exercises that you do. So there's some arm exercises. Usually there's like a new step, depending on what you can do. Sometimes walking, sometimes stair stepping, and they put you on these different apparatuses. You wear a heart monitor. They assess you for symptoms. So basically the most important thing is after you have a heart attack, we want to get you back and being active as soon as possible. Obviously we want to monitor you for symptoms, make sure you're in the target heart rate, get you comfortable exercising again, because the last thing that we want you to do is have a heart attack and then go back to being sedentary and being scared to do anything. They do education classes on diet, exercise, lifestyle changes. And heart failure is another subset of what we do. So people that have heart failure, which is a pump problem with the heart, usually the heart function is reduced and you have some fluid retention issues. That can be from a heart attack or can be a separate entity. We will get you into the exercise program that has been shown to improve survival, and also with the education piece about diet, lifestyle modification to try to keep you out of the hospital.
One other, just to add to what she's saying with cardiac rehab, after patients have had a heart attack, a lot of times they feel like they can't do anything. And so they're at home, and it's like, oh, I used to garden, and I used to go for walks with my friend, and I've just been home for the past 6 weeks, and I'm afraid that if I exert myself too much, something bad will happen. So another benefit of cardiac rehab is giving that subconscious the support and evidence it needs to see that, yes, you can exercise, you can move around, you can do your normal routines and activities. Just having that supervised exercise and the monitoring makes all the difference to the subconscious to give you more confidence to do your normal things too.
We do have something called phase 2 cardiac rehab where so my mom had bypass surgery in 2015. And she did cardiac rehab up until COVID in 2020. She paid out of pocket. She was in Michigan. But we have a similar program here where if you complete cardiac rehab and you like it and you think that it's helpful and you want to continue to exercise in a supervised environment, you're more than willing to continue to do that.
How do you all feel about patients with history of coronary artery disease, such as stenting or revascularization with a CABG, who have been lost to follow-up, have moved here from another town and hadn't seen a cardiologist in a number of years, and their personal physician was managing things? Do you think it's important to reestablish care?
Yes, I do, and I think we both see a decent number of those patients. And we don't necessarily start from scratch, but we try to establish a baseline. Have you been maintaining your blood pressure appropriately? Have you been taking your medications as prescribed? Are you on an antiplatelet therapy after you've been had a stent placed? What is your heart function? On almost all of those patients, I'll get an echocardiogram unless I've had one done very recently, but so that I can look at the actual images and see, is there any evidence of heart failure or valvular issues? So it's very important for anyone that has any known cardiac history or has had any intervention on their heart to see a cardiologist at least once a year.
Following up on that, when you talked about antiplatelets and medications specific for heart disease, there's all sorts of new classes of medications and new drugs hitting the market. The unfortunate thing that I encounter in my practice is the cost associated with those drugs. Do you all, can you kind of opine or give your opinion in regards to just having a frank conversation with your physician if your physician places you on a drug that you cannot afford or potentially couldn't get at a reasonable cost from a Medicare perspective?
Absolutely. So a lot of the newer, some of the newer cardiac medications, mostly with the AFib treatments, the anticoagulants are expensive. Unfortunately, the Medicare rules say that we can't give you those copay cards because Medicare supposedly has the cheapest drugs on the market. Obviously, I always tell people, we usually have access to samples if they're branded drugs. I personally try to use generic drugs in every aspect that I can, but some of it is a convenience issue and some of it's just not possible. There are some brand name drugs that are better, like Entresto, for instance, for heart failure has markedly better data than some of the older drugs, and we do try to use that when we can. But if you can't afford your medication, usually if it's a brand name drug, we usually have samples. A lot of the drug companies do have assistance programs, so like I will automatically usually fill out paperwork to submit. So basically I sign it, give it to you, you fill out your personal information, and you can submit it to the drug company to see if they'll help cover the cost or completely free. Obviously we can work on alternatives, but just don't stop taking your medicine. So if I usually tell people when I start them on a very expensive drug, if we have samples, I'll give you samples. 99% of the time we do. And I always tell them, especially if you have a mail order, to call first and see how much it costs. And if it's cost prohibitive, just call me back and we'll figure something else out.
Yeah. So the biggest thing that Dr. Shaw is saying is say something to your physician. Say something to your primary care physician or your cardiologist, because we have options, we have workarounds.
And make sure if you guys are getting mail order prescriptions from like CVS Caremark that you set a cost contact where if it's a certain amount of money, they have to contact you before they mail it, because unfortunately prescription drugs are not returnable, meaning once they send them to you, they will not take them back. A lot of times they set it at $250 and they'll send it to you if it's below $250. So I usually tell people, I usually cap it at 50. Call them and say, I want to be notified if any of these drugs are over $50. So they don't send them to you and you get billed for them.
So the takeaway from that, definitely be in contact with your physician and 100% stay on your medications or let them know ASAP. For those patients going home from the hospital after having a stent, it is incredibly important to stay on those medications to keep that patent and wide open, to keep feeding your heart oxygen.
And St. Francis has a program now where we give you 30 days of medication to go home with. So we at least get you the first month so we figure out how much everything is going to cost.
We had a question coming online, and I think this is just some level of education in regards to what this specific word means, because we kind of hit on this. But can you please discuss the presentation of angina and what that means?
So angina means heart pain. Pain actually created from poor blood flow through the coronary arteries. That when we say angina, that's exactly what that means. And usually that's after you have a blockage or a narrowing that's greater than 70%. And that can be from atherosclerosis or plaque buildup. In women, there's an entity called spontaneous coronary artery dissection, or SCAD, where the coronary arteries dissect or have a little tear. And if you think of a dissection, there's flow where there shouldn't be flow, in short. And the true space or the true tube is narrow enough to then cause chest pain, cause a heart attack. So angina is heart pain.
I've heard the word heart hero thrown around. How can I be my own heart hero and decrease my risk of heart disease?
First, you have to get a cape. But I think the biggest thing is, which has kind of been our overarching theme, I feel, is seeing your primary care physician, knowing what the risk factors are. And even if you don't know what the risk factors are, your primary care physician does. And they will be on the lookout for those things. And then trying to lead an overall healthy lifestyle and a heart-healthy lifestyle. Exercising routinely, eating the appropriate meals, stopping smoking. We didn't talk a lot about smoking, but quitting all tobacco products, and following those sorts of things. And then listening to your body, being in tune with your body, especially for women. As Dr. Shaw mentioned earlier, we have some of those non-specific symptoms. And while she told the story about her mother who no one paid attention, physicians didn't pay attention until she had a heart attack. You yourself don't write off your symptoms or how you're feeling. I'm just tired, I'm carrying a lot. Women, we are the caregivers. We do a lot, we push through a lot, and we just keep going. And if something's not right, trust that feeling, trust your gut, and get checked out.
At this time, I'd like to open this point of our lecture to questions from the audience.
My blood pressure is first thing in the morning, always 15, sometimes even up to 20 points higher. I take it before I even get out of bed, and then slowly, after I'm up a little while, it comes down. Why is that, and how do I deal with that?
I think like Dr. Williams talked about earlier, when you first wake up in the morning, you do have a kind of a surge of wake up. Like you wake up and that's usually brings on like some epinephrine and some norepinephrine and your body's waking up. So it can be more normal for your blood pressure to be a little bit higher. What I usually tell people is to make sure it's okay at nighttime, and if it goes down throughout the morning time, it's probably just a little bit higher because it's first thing in the morning and you're waking up.
Yes, I believe that couple of risk factors that need to be more emphasized are sleep deprivation and chronic stress, because those ones can lead to other risk factors like unhealthy eating, high blood pressure, just lack of sleep, and the chronic stress. I think they should be more emphasized about.
Yeah, so sleep is actually a huge, we did not talk about that, but sleep is a huge issue, and a lot of people in this country do not get enough of it. So some people function very nicely on not very much sleep, but it has been shown that, especially with people that work like not normal shifts that are up all night, they do have an increased risk of having high blood pressure, high cholesterol. Lack of sleep is very stressful on your body. So our recommendation is 7 to 8 hours a night. The main thing that I think now with insomnia that people have is, we're very plugged in society, and to try to like take away that screen an hour before you go to bed to help you sleep. And if you're having any sleep issues, so there's something called sleep hygiene, which is kind of what we talk about, like decreasing, like no caffeine before, like, I think it's 8 hours before you're supposed to go to sleep. Trying to limit your screen time, specifically an hour before you go to bed, trying to do things to kind of calm down at night so that you can kind of get your body used to sleeping. It's the same thing with kids though. A routine I think is very important for sleeping, that you do kind of the same thing at night. So like I do for my 4-year-old, we get him off the bed, we give him a bath, we read a story. The same thing for adults. Once you get in that mindset that you're going to go to sleep, it's a lot easier to go to sleep and stay asleep. I personally find that meditation is very helpful. When I wake up in the middle of the night with like racing thoughts, is to try to, clear your mind, and I do practice some mindfulness meditation. And so when I have those racing thoughts and I can't go back to sleep, I sometimes can go back to sleep when I try to focus and meditate.
You talked about it earlier when it comes to sleep apnea being a specific risk factor for having a heart attack or heart disease, cardiomyopathy. Can you kind of talk about what sleep apnea looks like from a patient perspective and what they might want to identify with their spousal sleep patterns as far as what they might be seeing and have not be known that this is a diagnosis?
So there are two major types of sleep apnea, central sleep apnea and obstructive sleep apnea. And oftentimes you may have been asked or noted that a family member or even yourself snores. We always ask, well, do you snore? It's like, well, where does that question come from? That's one of our conversational screening questions to see if you do have obstructive sleep apnea. Basically, when you're sleeping, the whole body relaxes, and you may have some compression of your airway just from everything relaxing here, then causing the snoring. But the next step further, when you're in a deeper sleep, in sleep apnea, patients actually stop breathing for a moment, and then the mind is saying, oh, I need oxygen, I need oxygen, I need oxygen, breathe, 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 breathe. And then you take a big breath, and then you start breathing again until, again, things are suppressed. And so when patients have those, that sort of rhythm throughout the evening or all night for years on end, that can then lead to these irregular heart rhythms and so forth. But sleep apnea is actually also associated with elevated blood pressure, is associated with weight gain, daytime fatigue or generalized fatigue, and then also being sleepy during the daytime where you're actually taking naps. I've seen many patients come in and say, I'm just so tired, I'm so tired, I'm so tired. And then I ask about the snoring. It's like, oh yeah, he snores all the time. St. Francis has a wonderful sleep center. We send them there and they have the sleep study done. Come to find out, I stopped breathing 27 times in a night. And sometimes that was for 2 seconds, sometimes it's for 15 seconds. So that's kind of how we navigate through the sleep apnea side of things. So it's actually pretty important. Another thing is that we have, there's a certain body habitus that would suggest one may have sleep apnea if you have a particularly thick neck, if you're obese, but that's not always true. Thin, fit individuals can also have sleep apnea.
I think the main thing about the sleep apnea is that basically what happens is you don't fully get into REM sleep because your body is constantly saying, wake up and breathe, wake up and breathe, wake up and breathe, and that's why you're so tired all the time. You have to have that REM cycle for that rejuvenating, restful sleep. If you're never going into REM sleep, you're never getting that refreshing sleep, and so you're gonna wake up tired even if you're sleeping 10 plus hours.
We're gonna work our way to the back.
I've been diagnosed with hypertrophic cardiomyopathy, and my last EKG said that there's a repolarization abnormality in the left ventricle. Can you explain that to me?
So usually with a hypertrophic cardiomyopathy, your walls are thicker. And so when they talk about a repolarization abnormality, that usually means that your EKG is, the thicker the walls, the larger the QRS complex, which is what shows us your actual heartbeat. And then sometimes you have an abnormality with your T waves, which is the time of the heart relaxing. And so basically because your walls are thicker, your EKG is not going to look completely normal. And so repolarization abnormality means that the electricity is conducting abnormally in your heart because the walls are thicker than in a normal heart. And so it's your electrical conduction system is different than, quote, normal because of your hypertrophic cardiomyopathy. Does that make sense?
That was well said.
Hi, I have a question about the cholesterol thing.
Mhm.
Okay, my cholesterol is 206, but my HDL was 106. So, and then my LDL was 93. So is that gonna be okay because my good cholesterol is higher than the range, but causing my cholesterol is over the 200, the maximum. How can I make it normal? Can I have to do something about it?
So the unique thing is that the cholesterol guidelines are always changing, making it somewhat challenging to say exactly what the goal is. Most recently, and correct me if I'm incorrect, but we want your bad cholesterol, which is the LDL cholesterol, if you have no other cardiac risk factors, haven't had a heart attack and so forth, less than 100 for your LDL cholesterol. Your HDL cholesterol is the good cholesterol that goes up if you're exercising. On average, I think the goal for women is around 40, 50.
Yeah. Good cholesterol is awesome.
And so I don't know that I've personally seen an LDL cholesterol greater than 60. And so we look at those numbers more so than the total cholesterol number, because you can have a very high LDL cholesterol that then contributes to your total cholesterol.
Your HDL, yeah.
HDL,
yeah,
yes.
So we talk about good and bad cholesterol. When you talk about cholesterol, there's a whole bunch of things that go in. So cholesterol there's something called triglycerides, which are free fatty acids that circulate. There's LDL, which is low density lipoprotein. There's something called VLDL. There's a whole bunch of different particles that contribute to the cholesterol. And then there's HDL, which is high density lipoprotein. HDL is what we call good cholesterol, meaning that higher levels of HDL have a good prognosticating, you have a good prognosticating effect, meaning that it's not going to hurt you. It's actually something that we like to see. Usually people that have cardiovascular events have low HDL, and there's no medication that brings HDL up, so genetically you probably have a good HDL, and if you're active and healthy, that's a good cholesterol profile. I don't really go by the total cholesterol because of situations like that. There's a bunch of things that can factor in. So I wouldn't go by that 200 number. I think your cholesterol is probably good.
It's hard or it's great in a lot of ways, the rise of patient education and having access to your records in real time. I mean, patients are seeing their results faster than I have a chance to review them.
Yeah.
But it's also important to realize not every patient, if it's outside of reference range, that doesn't necessarily mean that it's bad. It's an individualized approach, and you have to take everything into consideration. I think there was a question over here.
If I'm given an EKG today, can you determine an event that happened in the past, a week ago, a month ago?
Sometimes. So EKGs are about 70% for picking up previous heart attacks. So an EKG is a screening tool. It's not an end-all be-all. So it also depends. So lead placement is a really important factor when we do EKGs. If the EKG leads are not in the exact same place that they were when they were done, or if they're up too high, it can give you kind of skewed readings. But yes, an EKG can show a previous heart attack. Usually what we see is something called Q waves, which are downward deflections indicating that. So when you talk about electrical conduction in your heart, if you think of your heart like the muscle, like a steak, okay? So I can char the outside, right, and burn it, but the inside can still be pink. So when you've had a heart attack and you have scar tissue form, sometimes the scar tissue is not completely transmural, or sometimes it is. And so when the electrical conduction, the EKG is an electrical conduction, when it stops at a portion that's in a scar tissue that's not conducting electricity, we can see those downward deflections indicating that you have had a heart attack before. Also, an EKG can tell us about an acute events that you're having. Sometimes we look for what we call ST elevation or T wave inversions or changes on the EKG that can indicate that you're having an acute event if you're having symptoms or like recent symptoms. So yes, definitely you can get a lot of information from EKG.
Any other questions online or here in the audience? We have one more in the back with the hypertrophic cardiomyopathy.
In your practice, what do you see more often, systolic or diastolic heart failure? And what would be the outcome of both?
I think we see more, that's a loaded question.
Yeah.
Diastolic, classically we're seeing more congestive systolic heart failure. And that initially was encompassing the diagnosis of heart failure. But more recently, over, I don't know, the past 10 to 15 years, this entity of diastolic heart failure, which is a stiff heart contributing to heart failure, has become more prevalent. And so maybe now I think I'm seeing more like 50%, 50-50 of the two. And it really, your outcomes depend on which heart failure you are diagnosed with. If you're compensated, meaning you're taking the appropriate medications, your volume status is optimized, you're living a heart-healthy life, versus if you're decompensated and you're not taking medications, you're in and out of the hospital, those sorts of things. Those are the things that dictate how you do in the long run.
So usually, to kind of piggyback on that, systolic, so basically what she's talking about is do you have a pump failure or do you have a stiff heart? So if you think of we're gonna go back to the house analogy again, because I like that analogy. Main breaker, all right? So the power is going on to the house at full force. So systolic heart failure means that your heart is weak, so all of a sudden that generator that's powering your house is now operating at 30% instead of 100. So you have a pump problem. Diastolic heart failure is where the heart is stiff. So if you ever blew up balloons for a kid's party, the thin balloons that you blow up, it's easy to blow the air in and they inflate, but those thick ones you really got to blow hard, right, to get those to inflate. The same thing happens to your heart. The thicker the walls, the stiffer the heart. Sometimes the higher the filling pressures to get the blood in and out. You can have a combination of both systolic and diastolic dysfunction. I mean, you can have a weak heart and a stiff heart together. You can have one or the other. In terms of heart failure prognosis, and what Dr. Williams said, is basically your prognosis completely depends on how well your body's able to compensate with it.
I have an AFib condition, and I've been told I could be a candidate for the Watchman procedure at some point. Is that something that you all are familiar with as in terms of usefulness for
Absolutely. So Watchman procedure. So Watchman procedure, for those, we're going to go back into the AFib realm. So we're back in the electrical bucket. There's a risk of having a stroke with AFib, and there's something called the left atrial appendage, which is a pouch of tissue that comes off, and usually blood will pool in there when you lose the nice contraction of your heart and your heart fibrillates or wiggles. That's when the blood pools. Stagnation causes blood clots. And so for people that can't tolerate full dose anticoagulation or have bleeding problems, there's something called a Watchman, which is basically like a little umbrella, and we put that in there and deploy it, and it kind of plugs up that appendage. It's an excellent option. We have multiple people here that do them. We have a lot of really good success with that procedure. Our structural clinic with Dr. Fizel and Dr. Ensley they're the two main people that are doing those, and if you can get evaluated very easily.
We had a question coming online asking, or more of a question and a statement, but I have read that women's heart attacks are more related to microvascular disease as opposed to men's. Are the diagnostic tests in the ER the same for both men, or should women expect to get anything specific in the emergency department?
Women, no, you should get the same things. That's the real answer. Yes, there is a component of microvascular disease that's seen more prevalent in women than men. But one thing that has been noted in studies is that women presenting with chest pain symptoms or with heart attack symptoms may not be addressed or treated as efficiently or as taken as seriously when they present in the emergency department or at their primary care physician's office or their cardiologist's office, hopefully not. And so they're not being provided the same level of care out of a seriousness component. The options that we have to treat and diagnose are all the same. So there's no difference there, but it's how aggressive one is in diagnosing and treating where we find that discrepancy. And that's where women really need to advocate for themselves and say, hey, something is wrong, like I need to be checked out and you need to listen to me. And usually when you articulate your seriousness, hopefully that your physician or provider will take you seriously and do the right thing.
Oh, we got another question.
What
right
role of additional testing, such as homocysteine levels, do you see any benefit of testing that in your practice?
That is not something that's routinely, I'll just be honest, that's not something that's routinely checked. Maybe in specialty labs. I maybe have seen 1 or 2 patients that have come by with some outside lab work that have checked homocysteine levels. And to be frank with you, I tell them that I don't know what to do with this, but I do want to focus on the things that I know are tried and true and clear indicators of potential cardiovascular problems. And then if they wish to delve more into those things, then they'll have to look for a specialist that utilizes such markers routinely.
Could you please explain about aortic dissection, and also could that be hereditary?
Yes, so the aorta is the large blood tube that comes off of the heart, and it starts up here in your chest, and it actually splits into the arteries in the arm, gives off the carotids, and then goes all the way down into your abdomen and bifurcates into the legs. So the aorta, it's a pretty large blood tube. And yes, aortic dissection is where the arteries are made up of 3 layers. There's an intimal layer, which is a very thin layer that comes in direct contact with the blood. There's a muscular layer. Arteries are actually muscles, and they do contract, with the pulses, they do contract, and they do have it's a smooth muscle component. And then there's the adventitial layer, which is like kind of the outer layer. A dissection is where the artery wall splits apart. So the intimal layer splits apart from the muscular layer, and you end up, instead of a nice tube, you end up with a flap here, and it is a life-threatening emergency. So usually the chest pain that people experience with that is a tearing, ripping, very severe pain that starts up in the chest. So that's ascending or thoracic aneurysm. You can also have an aneurysm, which is a dilation. So it's usually a weakness in the muscle. So it's kind of like a area of defect where the blood pouches, or the wall pouches out. So instead of like this nice tube, you end up with like a big kind of outpouching there. Aneurysms in itself increase your risk for dissection. That you can have them in the ascending aorta, the thoracic aorta, or the abdominal aorta. Family history definitely plays a part in that. If you have a family history of dissection, definitely it's good to get screened. St. Francis also offers a screening test. It's part of a vascular screening package where they do a ultrasound of your abdominal aorta. Usually anybody over the age of, I think it's 75 smoker, or 65. 65
yeah.
Smoker does need a screening. If you've ever smoked in your life, you do need a screening ultrasound to make sure, because that significantly increases your risk of developing abdominal aortic aneurysm. So we do offer a screening package where they'll do I think it's $99. They do a carotid screening, ABIs, and a screening for your abdominal aorta. Specifically, thoracic or aortic dissections definitely do run in families. There are some other genetic issues that go along with that, something called Marfan syndrome. There's other connective tissue diseases that do increase your risk of dissections, like something called Ehlers-Danlos, or there's usually connective tissue diseases with the large vessels.
Thank you for that, Dr. Shaw. I know a lot of people in my practice do end up getting lifeline screenings, and I just put a little plug out here to say that St. Francis might be cheaper. So I know the Medicare population gets solicited in the mail to do these things, but it's nothing special. I believe there was another question. Maybe not. All right. Are there any other questions online or in the audience, or we might? One more. Last question of the evening. Is there any age limit to getting a leaky left mitral valve corrected?
So actually, no, we do have a lot more. So in terms of valvular heart disease, so we're going to go into another whole aspect of the heart. So the heart valves are kind of what allows the blood crosses through to get to the different chambers of the heart and then to get outside of the body. So the mitral valve is on the left side of the heart, and it connects the left atrium, which drains all the blood from the lungs. It connects the left atrium to the left ventricle, so the oxygenated blood from the lungs drains into the left atrium, goes through the mitral valve, then into the left ventricle, then out the aorta, into your body, and gives your body oxygenated blood. The mitral valve can become, any valve can become tight or leaky. A lot of times, 10, 15 years ago, the only way to fix those leaky or tight valves was to do open heart surgery. Luckily, nowadays we have a lot of very good progressive techniques that have had patients avoid surgery. So in terms of the aortic valve, there's something called a TAVR or transcatheter aortic valve. So if that valve is very tight, it's mostly indicated for that instead of the leakiness. You can get, it's like a valve on a stent, and so they actually go in through the legs and they can fix that valve without actually having to open your heart. In terms of the mitral valve, there's multiple different ways to fix that and the aortic valve, something called, there's a full sternotomy, which is a full open heart surgery. There's minimally invasive ways where they do a small thoracotomy incision. And then there's, and for the mitral valve, there's something called a mitral clip. And so the mitral clip is actually exactly what you think it is, where we kind of pull the valve together and clip it to decrease the leakiness. So there's absolutely no age limit on getting evaluated. A lot of times what we do is base it on symptoms, your heart function, and there's a whole routine process. But there are a lot of significant surgical risk of procedures now to fix heart valves.
So within the St. Francis heart specialty groups between thoracic surgery and interventional cardiologists and cardiologists such as yourselves, you're going to be able to find the right care at the right time,
Absolutely.
depending on what the etiology of your valvular disease is.
So we have a multidisciplinary valve clinic where you're evaluated by our structural cardiology team as well as a surgical team together, and they will. It's an individualized evaluation where they figure out what the best operative plan is to fix whatever valvular problem you have.
Well, that's wonderful. I appreciate you, Dr. Shaw, as well as Dr. Williams, taking the time out of your busy practices and schedules to be here and educate those in the audience as well as those online. Thank you all for being in attendance. Final thing, how would you recommend that patients get a hold of you or your practice if they're wanting to see a St. Francis cardiologist?
You can just go online to St. Francis website, and if you just type in cardiology, or there should be a specialty drop-down box, you'll be able to see our practice there. It's Cardiology of Tulsa, and I think our name will be changing in the future as we continue to grow into a larger institute. But yeah, right there on the St. Francis website.
Well, again, I can't thank you both enough for being here, and as well as the audience with all their questions. So, thank you.